A pleasure to speak today at the Breast Cancer Conference in Gaza Strip, and my topic would be screening guidelines, which one to pick. Before we answer the big question on screening guidelines, which one to follow or pick, we need to consider three factors. The regional variations in breast cancer related morbidity and mortality will impact local program strategies and patients' outcome. Screening should be coupled with early access to breast cancer diagnosis, treatment, and palliative services. Comprehensive quality assurance program is essential to maintain an appropriate balance between benefits and harms. And we all agree on the fact that breast cancer screening saves lives. With that, the outline of my talk would be overview of the differences in global breast cancer screening guidelines. What do the experts say? And then we're going to bring it all together. Early detection. Early detection is divided into screening and early diagnosis. Screening is the examination of asymptomatic women to detect abnormalities which can lead to a diagnosis of early-stage breast cancer. Early diagnosis involves recognized early signs and symptoms that would prompt early diagnostic workup, leading to more effective treatment of breast cancer. So until we can prevent breast cancer, early detection, including screening and early diagnosis, are crucial. Breast cancer screening can be regular screening, which is the most reliable way to find early-stage breast cancer, with mortality reduction up to 40%. So early breast cancer is defined by the following: small, negative lymph nodes, and has not spread, so no metastasis. The ideal screening tool should be highly sensitive, highly specific, inexpensive, and non-invasive. Clinical and self-breast examination, mammography, ultrasound, MRI, and genetic testings are all considered part of the screening tools that might be executed. Who are the stakeholders in early detection? I would say the patients are number one, because we really have to make sure that they understand the benefits and harms and make their informed decisions. Healthcare professionals in multidisciplinary specialties, health policy makers, which are key in enabling the screening programs, vendors, scientists, which would support with equipment and evidence, payers, insurance, donors, advocates, and general population in general. So it is a teamwork. Awareness is very important. Education of both the targeted population and their providers, health providers, is very important. And then empowerment. We need to empower those who are in charge of having the screening program executed. The ACR and Society of Breast Imaging in USA are recommending the following. The ACR and Society of Breast Imaging recommending annual mammography screening beginning at the age of 40, which provides the greatest mortality reduction, diagnosis at earlier stage, better surgical options, and more effective chemotherapy. In Canada, in Ontario, there is the Ontario Breast Screening Program, which basically has two arms, for average risk women and for women with high risk. And it's one of the unique programs across the world because it basically recruits women that have high risk to get both the MRI and the screening mammography done. For women outside the screen eligible population, basically there is a recommendation that the women need to discuss that with their physicians to ensure that they're getting the appropriate screening. So the OBSP, the Ontario Breast Screening Program, recommends screening at the age of 50 for women at average risk. When they are in their 40s, they are encouraged, as I said, to make a personal decision based on the discussion or consultation with their health care providers. Women over the age of 74 can be screened within the OBSP. However, they are encouraged to make a personal decision about breast cancer screening in consultations with their providers. The OBSP will not recall women, like they will not send them invitation or reminders beyond the age of 74. So to continue screening through OBSP, a referral is required from a woman's healthcare provider after the age of 74. Here's an example of screening. You can see here in this right breast that the woman has developed over time. Okay, here is my mouse, you can see it here. An asymmetry, and that asymmetry turned out to be malignant. Another case in 2016, you can see maybe an asymmetry, but with time, it progressed after 1 year to architectural distortion. When we do spot compression views, it's easily detected where the architectural distortion persisted. The patient was taken to ultrasound. You can see a lesion that's hypoechoic, taller than wide, posterior acoustic enhancement, and even there is an echogenic halo, which tells us this is truly or probably highly malignant. And here's the patient after she got the biopsy. We did wire localization, and she had the excision. This is an example for early diagnosis. This woman here was lucky because the cancer developed superficially in the breast because she has a large breast, as you can see here. She's young, so she's not even eligible for breast cancer screening. She's 37, but ended up feeling a lump, and she did the right things by coming forward, getting her mammogram and ultrasound done. And that's what we say early diagnosis because the lesion was small and there was no metastasis. However, mammography is really give us a lot of limitations, especially in the heterogeneously dense breast. But this is a breast with scattered fibroglandular tissues, as you can see here in 2014, then came back in 2015, a lesion identified in the upper outer breast, but also unfortunately was missed. Then the patient came back in 2018 with a mass that has increased in size with architectural distortion, was taken to ultrasound, and showed us that this lesion is actually very suspicious, turned out to be cancer. So quality program is very important in assessing factors that led to delayed diagnosis with the screening tool. So what most guidelines have in common? Here are the items that are really in common amongst a lot of screening programs. Mammography is the cornerstone of breast cancer screening. Despite the limitations of screening mammography, a negative or normal screening test gives a peace of mind for women and the family. If finding cancer earlier does not affect the ultimate outcome, which is mortality, morbidity, or quality of life, it may be more harmful than beneficial. So what most guidelines don't have in common? Here are the factors. Coverage and exclusion of age groups of eligible women for screening. Frequency of screening mammography, every 1 year or every 2 years. Endorsing or not endorsing the self and clinical breast examination. Utility of adjunctive imaging modalities like ultrasound and breast MRI. And we know this is now a hot topic when it comes to breast density. Tailored screening to high-risk population and genetic testing. Outreach to underserved population. Addressing breast density. Utility of emerging technologies such as tomosynthesis and contrast-enhanced mammography. Transgender screening guidelines. Ethical considerations. We need to address the misconceptions and acknowledge bias and clarify uncertainties in honest, respectful, and non-perspective messaging. Value patients' autonomy and privacy. Foster transparent learning culture leading to justifiable decisions and policies. Participatory medicine. True partnership between patients and healthcare providers where patients become responsible drivers for their own health. So how about non-eligible women, for example? What is the right decision? So overall, the process of decision-making regarding screening for breast cancer, whether at national level, which is the policymaking, or at health provider level, which is the implementation arm, is not about making the right decision. It's rather about creating the ethical space that would allow for accountability, for reasonableness, that would justify the decision within the relevant and local cultural settings. Like I would say in a nutshell, we don't have to do a copy and paste from another program, but this needs a more honest discussion and brainstorming with a transparent conversation between stakeholders within the given country or city to start a suitable national screening program. So here are the experts' opinion. In an ideal world with available resources, what guidelines would you recommend for breast cancer screening? This was the question asked for those experts, and here is what they told me. Dr. Ben Anderson, who is the medical officer at WHO for cancer control, he highlighted the following. Are we asking the right questions about screening? The evidence is strong for mortality reduction with mammographic screening for women above the age of 45. Often undiscussed is what health systems require to optimize early diagnosis for women outside of the screening age group, such as women under 40. Even in countries with population-based screening programs, at least half of breast cancers are diagnosed clinically based on symptoms. Awareness education, clinical training, and patient navigation are all essential to facilitate prompt and accurate cancer diagnosis. Moving on to Dr. Julie Grallo, who is the Chief Medical Officer at American Cancer Society, ASCO. So here are the guidelines. In an ideal world with unlimited resources, Dr. Grallo said, I'm probably most in alignment with the current American Cancer Society guidelines, including not only mammography, but also MRI for high risk. She also supports doing breast cancer risk assessment and tailoring recommendations based on age of initiation, interval between mammograms, to basically have that matched with the risk of the patient. Dr. Derek Muradelli, who is the previous radiologist in chief for the Ontario Breast Screening Program, focused on personalized screening and the integration of risk assessment and breast density. He suggests offering organized screening program, and the risk assessment would be based on clinical history for women who may be at high risk for developing breast cancer with genetic assessment starting at the age of 25. So the average risk woman would get annual mammography at the age of 40, and then at the age of 50, they will get a mammogram every 2 years. The above average risk, which is basically women that do not meet the criteria for being part of the high risk program, but yet they're not average risk, they get annual screening mammography at the age of 40. And for women with dense breasts, they can get MRI. As for the high risk women, they can start having annual screening mammogram at the age of 30, along with MRI. We need also to discuss, as per Dr. Muradelli, the screening sedation, like when do we need to stop? And patients need to have an informed decision. She needs to know the benefits and harms of screening. In terms of equipment, approach digital mammography and tomosynthesis combination would be helpful. Dr. Jean Seeley, who is the president of Canadian Society of Breast Imaging, talked about the role of supplemental screening, which is basically we're talking about adjunctive modalities. She recommends the following: annual screening mammograms between the age of 40 to 49-year-old women, screening mammography every 1 to 2 years for women 50 and older, and if life expectancy is more than 7 years, as old as when women are above 80. For dense breast, supplemental screening with MRI every 3 years for those women with dense breast, heterogeneously dense breast and dense breast, alternating with mammograms every 2 years. If unable to have MRI, add breast ultrasound every year to the annual mammogram. If supplemental MRI screening for dense breast is added, screening mammography can be reduced to every 2 years instead of annual screening. If no supplemental screening is done, then mammography needs to be every year. Dr. Jessica Liang, who's the immediate past president of the Society of Breast Imaging, and who's also going to give a wonderful talk today about utility of MRI, she's talking about screening mammography, which basically has the fact that it does save lives. Screening mammography is a life-saving tool, and multiple studies over decades of time show just that. We believe that annual mammography starting at the age of 40 would save the most lives. As in any medical decision, costs are considered here, including false positives and patient anxiety. But we believe it's important that the benefits and risk of mammography should be done by women, not for women. Moving forward, the opinion of Dr. Durriya Salim, who is the founder of the Egyptian National Screening Program. She talked about the importance of integration of artificial intelligence and awareness campaigns. Dr. Salim focused on the fact that there should be awareness preceding any screening program, basically to draw the officials' attention to the high mortality and high expenses in treating late-stage breast cancer. And also there should be some awareness about male breast cancer. Considering all the above, here's what we took away. Annual screening starting at the age of 40 for average risk women finds more screening detected cancers, smaller size tumors, and fewer interval cancers than longer screening intervals. Screened women in their 40s are most likely to have early stage disease, negative lymph nodes, and smaller tumors than unscreened women. Delaying screening until the age of 45 or 50, there is loss of life to breast cancer and adversely affects minority women in particular. Screening should continue past the age of 74 without an upper age limit unless severe comorbidities limit life expectancy. I'm moving on to bring it all together. Awareness is key. Comprehensive approach for high quality multidisciplinary breast cancer care is important, from screening, diagnostic tools, treatment, and palliation. Utility of available multimodality screening based on local health policy will be leveraging scientific evidence, and advanced technology is important, such as AI. So the more important question is, how do we establish effective early diagnosis programs so that countries are prepared to begin screening if resources and political will are present? So in summary, screening guidelines, which one to pick or follow, need to have tailored strategies, organized program with overarching quality and research. Risk assessments should drive who, when, and what to screen. Ethical considerations, especially how about the non-eligible women and how can they get included, and patient autonomy. In other words, we really need to lower the stage of breast cancer diagnosis from big tumors to very small, only mammographic detected tumors. Thank you very much for your attention.